Welcome. We are examining the advanced mechanics of infection control in transplant units. Cancer patients undergoing HCT or SOT face a massive burden of infectious complications, particularly in the early post-transplant phase. This session moves beyond simple precautions to the defense-in-depth model required for patient survival. Slide 2. The clinical mandate. Recipients experience a total collapse of endogenous defenses, creating extreme susceptibility to environmental molds like Aspergillus and respiratory viruses during profound neutropenia. Because standard contact and droplet precautions fail to mitigate these airborne threats, survival requires engineered environmental isolation. Slide 3. The defense-in-depth model. We utilize 4 shields: mechanical, aerodynamic, human interface, and operational. This protective isolation, or reverse isolation, acts as a biomechanical barrier to shield the patient specifically from the hospital's external milieu. Slide 4. Risk stratification, graft and donor vectors. Risk is stratified by graft biologicals. Allogeneic transplants carry higher risk than autologous or syngeneic. While bone marrow from unrelated donors escalates risk, cord blood grafts represent the extreme risk vector, possessing the highest risk profile among all graft sources. Slide 5. Temporal and clinical risk amplifiers. Vulnerability peaks during the conditioning phase and engraftment horizon. Factors like grade 3 to 4 acute GVHD or delayed neutrophil engraftment exponentially increase susceptibility. Conversely, lower-intensity conditioning regimens in the first 3 months post-transplant may offer an inverse risk relationship. Slide 6. Shield 1. Architecture of the protective environment. The mechanical shield utilizes unidirectional, laminar flow. HEPA, filtered air intake, occurs strictly on one side of the room, creating a continuous sweeping vector across the patient bed before exhausting on the opposite side to prevent recirculation. Slide 7. Physics of HEPA and the 0.3 micron standard. We mandate HEPA filters with 99.97% efficiency for particles equal to 0.3 mm in diameter. While larger fungal spores are caught via direct impaction, this standard ensures that even the hardest to catch 0.3 mm particles, the most penetrating particle size, MPPS, are mathematically eliminated. Slide 8. Thermodynamic clearance, the 12 ACH washout. Air turnover is governed by a minimum of 12 air changes per hour, ACH. This ensures the entire room volume is replaced every 5 minutes, rapidly exhausting any generated pathogens before they can settle on the vulnerable host. Slide 9. Shield 2. Aerodynamic isolation. Aerodynamic isolation requires a consistent positive pressure differential of 0.25 Pa between the patient room and the hallway. This outward force physically repels hallway air, even when the door is momentarily opened. This pressure must be continuously monitored via hardwired sensors. Slide 10. Architectural microsealing. Pressure cannot be maintained in porous spaces. It requires rigorous microsealing of all floor joints, wall outlets, and ceiling tiles. Microleaks act as failure vectors, creating turbulent vortices that pull untreated air from wall cavities into the sterile sphere. Slide 11. Diagnostic matrix, AIIR versus PE. It is vital to distinguish between airborne infection isolation rooms, AIIR, and the protective environment, PE. While AIIR uses negative pressure to protect the hospital from the patient, the PE uses positive pressure to protect the patient from the hospital environment. Slide 12. Shield 3, the human interface vector. Once engineering is established, the human vector is the sole path for pathogens. Strict adherence to hand hygiene is the non-negotiable foundation of this shield. Any breach introduces transient hospital flora directly past our biomechanical defenses. Slide 13. Barrier protocols and PPE geometry. Entry must be absolutely restricted. All staff and permitted visitors must don mandatory PPE, gloves, surgical masks, and full coverage gowns before crossing the positive pressure threshold. Visitors must undergo strict screening and follow identical hand hygiene protocols. Slide 14. Shield IV, the infection-free patient journey. In outpatient settings, transplant patients must be fast-tracked through waiting rooms to minimize exposure to respiratory droplets. For invasive procedures, They should be scheduled as the first case of the day to ensure maximum baseline sterility. Slide 15. Eradication of environmental and dietary reservoirs. We enforce a total botanical prohibition, as flowers and soil are massive reservoirs for Pseudomonas and Aspergillus. Dietarily, we provide low bacterial or sterile food to prevent the introduction of foodborne pathogens into the compromised GI tract. Slide 16. Synthesis, the architecture of unit failure. Catastrophic infections occur only when mechanical degradation, such as an overdue HEPA filter, perfectly aligns with human or operational non-compliance. Our redundant shields are designed so that a single breach does not lead to mortality, provided the other layers hold. Slide 17. The blueprint maintained. Transplant infection control is an engineered ecosystem. While 12 ACH and a positive pressure of ESAR 2.5 PA provide the foundation, survival ultimately depends on zero tolerance for protocol variants in clinical bundles and operational stewardship.